Hello, my name is Samantha Anderson. I am enrolled in Maryville University's BSN to DNP program with an FNP concentration. Today, I am presenting my DNP scholarly project titled Development of a Clinical Practice Guideline for Asthma Care in Schools. Here you can see the names of my project chair and community member. In this scholarly project, I address the issue of asthma's impact on the pediatric population. I approach the topic from my years of experience as a school nurse. Asthma is a common chronic condition among school-aged children, impacting over 7 million youth. About 1 in 12 children up to age 17 have asthma. The symptoms can influence a child's quality of life, and the reality of managing the chronic condition can be a strain on both the child and their family, affecting emotional well-being, academic success, and financial stability. Inhalers are commonly prescribed for the management of asthma, but are often misused by children. The correct use of a metered dose inhaler requires the execution of specific ordered and coordinated steps. These steps can be difficult for any patient with asthma, regardless of age. When inhalation is correctly coordinated with actuation of the metered dose inhaler, there is still some deposition of medication particles in the mouth and throat, with only about 52% of the dose being delivered to the alveolar airways. Improper technique results in even less medication reaching the lungs where it is needed. Due to its prevalence and impact, standard recommendations have been established for asthma care. The National Heart, Lung, and Blood Institute recommends the application of their asthma management guidelines at all levels of care. Since children with asthma spend a good portion of their days at school, the care that school nurses deliver is a critical part of the overall management of asthma. Although we know that clinical practice guidelines are valuable resources to guide care decisions, they are not commonly developed for use in the school nursing field. The purpose of this scholarly project was to develop an evidence-based clinical practice guideline for school nurses delivering care to students with asthma in a large metropolitan school district. I aimed through the project to apply evidence to practice by developing a clinical practice guideline for use in schools, a practice that is not widely adopted in the field of school nursing. I identified the Haynes and Jones translation model as a good fit for this project. The model emphasizes that healthcare providers should engage in multiple approaches to speed up the implementation of research findings in practice. Evidence-based guidelines are one of the methods Haynes and Jones describe as a means to change healthcare through the critical appraisal of evidence to direct practice decisions. They encourage a balance between the dissemination of well-researched findings and continued study in areas that demand more evidence before there is widespread acceptance. According to the model, clinical practice guidelines are considered a positive force in moving toward the adoption of evidence-based care, and can foster a sense of local ownership when developed by those who will use them. Let's move now into a discussion of my project's methods. The project I completed was a non-intervention project involving the development of a clinical practice guideline for the delivery of asthma nursing care in schools. This design is unique in that I did not implement an intervention and collect data related to the impact of the intervention. Rather, I created a clinical practice guideline and gathered data on the quality of the guideline. This project did not involve the sampling of participants or the implementation of an intervention in a specific setting. The participants of this project were the reviewers who were selected to provide feedback on the quality of the guideline. The setting was a large metropolitan school district in Missouri, at which I initially identified the need and then later presented the guideline to them for consideration of adopting it as an official district document. The data collection process involved presenting the clinical practice guideline to 4 healthcare professionals to have them critically appraise the quality of the guideline using the Appraisal of Guidelines for Research and Evaluation to, or Agree to, instrument. Instructions provided with the instrument indicate that at least 2, but preferably 4 appraisers complete the tool as part of the data collection process. The 4 reviewers, or appraisers, who participated in this project included a pediatrician, a family nurse practitioner, and 2 master's prepared school nurses. These 4 healthcare professionals used the Agrees-To instrument to provide a critical review of the quality of the guideline, which made up the project's data. The Agree-To instrument is a publicly available tool that can be used to evaluate the development of clinical practice guidelines. It is simple and generic, allowing it to be used in any area of healthcare. Evidence supports the validity and the reliability of the instrument, and those using the tool can be confident that the results can differentiate high-quality guidelines from those with poor quality. It contains 23 items that are organized into 6 domains, including scope and purpose, stakeholder involvement, rigor of development, clarity of presentation, applicability, and editorial independence. There are also 2 items that address the overall quality of the guideline. The clinical practice guideline I developed for this project was not comprehensive in its approach to asthma management. Rather, it focused on 3 themes that were identified through the literature review. The first identified theme was the value of school nurses in the management of chronic conditions such as asthma. School nurses have regular and sustained interaction with their patient population, sometimes over multiple years. Their daily interactions with students promote a relationship not found in other practice settings. School nurses know their students and their families and are able to tailor care in order to meet individual needs. The pediatric population spends a large portion of their day at school and are used to receiving education in that setting, making the delivery of asthma education by a school nurse a natural extension of their day. These factors contribute to the vital role school nurses play on an interdisciplinary healthcare team and support the impact they can have in managing chronic conditions, including asthma. Studies have found that their involvement increases the delivery of a comprehensive asthma management plan for children with asthma. A second theme identified during the literature review was the benefit of using accessory devices such as spacers and chambers to administer inhaled medications. I mentioned earlier that the proper administration of inhaled medications can be difficult, especially for pediatric patients. Accessory devices are feasible options to improve the administration of inhaled medications, reducing the deposition of medication in the mouth and throat, and with more convenience than a nebulizer. Something that stood out to me while reviewing the evidence is that one study found that accessory devices performed similarly to jet nebulizers when used to treat asthma exacerbations. The performance of an accessory device varies based on the design and structure of the device itself. Anti-static, valved holding chambers deliver a similar drug amount compared to a metered dose inhaler alone, reduce the amount of medication remaining on the walls of the device, and deliver high fine particle doses. While the use of a face mask is possible with an accessory device, the seal between the mask and the patient's face can impact the function of the device. Therefore, the use of an anti-static, valved holding chamber without a face mask is the optimal accessory device. The final theme I identified during the literature review was the improvement seen in inhaler technique after the patient has received training on proper inhaler technique. Now, the researchers found that the education could be delivered through multiple formats, including verbal counseling, training devices, and written materials. Whatever the strategy, the common finding was that inhaler technique improved after a patient received education that addressed accurate inhaler technique. Additionally, studies found that inhaler technique can fade over time, so the regular delivery of training is critical for sustained technique improvement. To mitigate this risk of worsening inhaler technique over time, education and checking for proper use should be a part of regular healthcare visits. Yet, a survey of adolescents and their parents found that patients are often prescribed an inhaler without receiving any instruction on proper use of the device. Asthma education improves multiple health outcomes for students with asthma. Given the importance of regular asthma education, it was discouraging to learn that it occurs at fewer than 12% of primary care visits. The results of the literature review were then used in the development of the clinical practice guideline. I used the National Association of School Nurses model for developing clinical practice guidelines, or rather, a version of the model. The process included grading the strength of the evidence and reporting it as part of the guideline so that the audience can see the strength of the evidence behind the recommendations. The National Association of School Nurses model also mentions the use of the Agree To instrument. As mentioned before, the guidelines recommendations were focused on the themes identified in the literature review and supported by the evidence. I have summarized the recommendations on this slide. For Theme 1, practice recommendations included school nurses establishing positive relationships through consistent interaction, delivering comprehensive care to address the needs of students with asthma, routine delivery of asthma education, and tailoring asthma care to the individual needs of the student and family to eliminate barriers to successful management of the chronic condition. The district for which the guideline was developed already has access to an asthma education program called Teaming Up for Asthma Control, and some district nurses have already received training through a professional development day. While the resource is available, use of the program is not standardized throughout the district. A major recommendation of this guideline would be to standardize the delivery of asthma education to students with asthma. Practice recommendations based on Theme 2 included the use of accessory devices for administering inhaled medications, providing accessory devices to students who are unable to provide one for school use, and nurses working with students to promote the student's successful use of accessory devices for optimal medication delivery. At the time of my project's start, the district had access to a grant that provided anti-static valved holding chambers for student use at no cost. Another major recommendation of this guideline is that the use of these devices be standardized for all students with asthma. The third theme served as the foundation for additional practice recommendations that encouraged routine training on proper inhaler technique and regularly checking technique so that improper use can be corrected. Altogether, the clinical practice guideline document contained background on the significance of the issue, a statement of purpose, description of methods for developing the guideline, definitions, an explanation of the literature review process, and an exploration of how the identified themes informed the guideline's practice recommendations. The standards for grading the quality of evidence, a summary of the articles included in the literature review, and the practice recommendations were also included. All of the information was then presented to reviewers for them to critique the quality of the guideline. We've explored the project's methods. Now allow me to present the results of my project. As I stated in the previous slide, after creating the clinical practice guideline, I began the data collection process by presenting the guideline to 4 reviewers and asking for their feedback using the Agree To instrument. Following the instrument's instructions, each appraiser assigned a score for the Agree To's first 23 items using a 7-point scale. A score of 1 indicated that the appraiser strongly disagreed, while a 7 represented strongly agree. The appraisers were also asked to provide answers for 2 additional items that address the overall quality of the guideline, which I will talk about in a later slide. Data analysis followed the instructions provided with the Agree To instrument. Totals were calculated by adding the appraiser's scores for the items within each domain. Those totals were added together to compute the overall domain total, which represented the scores provided by all 4 appraisers for each domain. You can see the domain totals in the bar graph included on this slide. The graph shows a comparison of the total points possible to the awarded points for each domain. The light blue bars indicate the total points that could have possibly been awarded, and the dark blue bars show the total points that were awarded by the 4 appraisers. As you can see, the guideline scored well across all 6 domains. These domain totals were then used to calculate scaled domain scores, which I will explore further in the next slide. Like the rest of the data analysis, the scaled domain quality scores were calculated following the Agree To's instructions. The scaled domain scores could then be used to identify the strengths and weaknesses of the clinical practice guideline. The Agree To does not establish a standard domain quality score that must be met for the guideline to be considered of high or low quality. Instead, those using the tool are given the latitude to establish thresholds in various ways. I could have decided to prioritize specific domains, establish a threshold that all domains must meet, establish a different threshold for each domain, or set expectations for improvement of domain scores over time. For this project, I chose to establish a quality threshold of 85% across all domains. That means a scaled domain score lower than 85% would indicate an area of weakness within the clinical practice guideline that must be addressed. In comparison, a higher scaled domain score would show adequate strength of the guideline. You can see in the table provided that the domain quality scores range from 90% to 100%, with all scores exceeding the minimum threshold for quality. Therefore, the guideline was identified as having sufficient strength across all domains. The results also included the feedback the appraisers provided on the Agree-To instrument's 2 global items. The first global item asked appraisers to rate the overall quality of the guideline using a 7-point scale, with 7 being the highest score possible. The second global item asked reviewers whether they would recommend the use of the guideline, with possible answers being yes, yes with modifications, or no. All 4 of the appraisers awarded the guideline the highest score possible when asked to rate the overall quality of the guideline. Additionally, they each answered yes, they would recommend the guideline for use. The results demonstrate the quality of the clinical practice guideline and the methodology used to develop it, and the potential benefits of the guideline to direct the delivery of nursing care for students with asthma in schools. While the results support the quality of the clinical practice guideline, it is important to look critically at the project in order to identify strengths and limitations. The strengths of the project include the use of the Agree-To instrument, which is beneficial in differentiating high-quality guidelines from those with low quality. The risk of bias is decreased by choosing an established tool that directs reviewers in its proper use. If I had developed a tool on my own, it likely would not have been as comprehensive as the Agree-To. Use of the Agree-To instrument ensured that all reviewers provided a thorough review of the guideline. Another strength of my project is the number of appraisers I contacted for feedback on the clinical practice guideline. As mentioned before, I collected feedback from 4 appraisers, a pediatrician, a family nurse practitioner, and 2 master's prepared nurses. Their varied healthcare roles, backgrounds, and experience with the pediatric population were valuable when reviewing the guideline. A limitation of my project is the lack of comments provided by reviewers using the Agree-To instrument. In addition to scoring each item, the appraisers were able to leave comments. However, none of the appraisers chose to leave comments that could be analyzed. Thus, the results of my project are missing the value the reviewers' words could have added. A second limitation is that the clinical practice guideline is not exhaustive. I had to limit the focus of the guideline to fit within the scholarly project timeline. I do believe that the developed guideline provides a good starting point for use in a school district. The guideline can be expanded as more evidence is reviewed, addressing other topics related to asthma care in school. The final limitation is that I developed the guideline independently. According to the National Association for School Nurses model, it is recommended that a team work together to develop guidelines. I did not enlist a team since this project was completed as part of an academic requirement and needed to reflect my independent efforts. While unique, this project meets the expectations of a DNP project, which is an academic endeavor that addresses an identified need within a practice setting. DNP project results should facilitate change or improvement to positively impact the health of individuals or a population. My DNP project addresses an identified need in the field of school nursing, and its results demonstrate the potential of the clinical practice guideline to positively impact the health of students with asthma. This project demonstrates a process by which quality evidence-based clinical practice guidelines can be developed for the field of school nursing. The use of clinical practice guidelines promotes standardized care and may reduce health disparities by promoting the same care throughout the community served by the district and improving health outcomes for all students with asthma. If a school district would choose to adopt the guidelines recommendations, they would be considered innovative since the field of school nursing has not yet widely adopted the development of clinical practice guidelines. Additionally, the project establishes a valuable path to create additional guidelines addressing other common diagnoses among school-aged children, including seizure disorders, allergies, and diabetes. The project also has implications for future research. Extending the understanding of this project through a study that looks at the impact of implementing the clinical practice guideline would contribute valuable information to the foundation of knowledge regarding school nursing and asthma care in the school setting. Personally, I can also say that this project will have implications on my future practice. I'm a registered nurse who's preparing to enter the advanced practice field in the next few months. I can say that the process of completing this project will absolutely shape how I provide asthma care. I intend to increase the percentage of providers that address asthma education, including proper inhaler technique, at routine care appointments. In summary, this project demonstrated the development of a clinical practice guideline that was found to be of sufficient quality to be recommended for use in the field of school nursing. The results of the project support the potential of the clinical practice guideline to positively impact multiple health outcomes for students with asthma. It demonstrates the translation of evidence to practice to address an area of need in school nursing and to positively impact the health of students with asthma. While completing the BSN to DNP program has been a significant challenge, I'm grateful to be entering the advanced practice field with the lessons of the DNP process fresh in my mind. I feel more prepared to critically appraise evidence and incorporate it in my clinical decision-making process. Throughout the program, the DNP courses have challenged me to think about leadership and change. I feel more prepared to be a positive member of the profession and look forward to the ways I can put these new skills into action, whether it be through my own practice, engagement in leadership opportunities, or as a future educator. This concludes my presentation. Thank you for your time and attention. The following slides contain the references used for this presentation. Thank you.